Hi everyone. Welcome again to the Medicaid Insights Colloquium. Thank you all for being here today. My name is Will Shapiro. I'm an assistant professor in health policy and economics at Weill Cornell in New York. And as usual, we're going to start by going over a quick notes for our time together today. So this session will run for about an hour, including 40 minutes of presentation, followed by 20 minutes of Q&A. Next slide, please. Great. And because there are so many of you joining us today, we ask that you please refrain from using the raise the hand function. And instead, if you have a question during the presentation, you can submit it at any time by clicking on the Q&A button at the bottom of your Zoom window, and we'll get to as many questions as we can after the presentation. I want to take a quick moment to recognize my fellow members on the MIC Planning Committee. That includes John McConnell, who's at OHSU, along with our new committee member, Dr. Megan Cole. Dr. Cole is the Division Director of Health Policy and Insurance Research in the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute. So with that, I have the great pleasure of introducing our fantastic speaker today, Hannah Maniates. Hannah is the Director of Medicaid Programming at the National Association of Medicaid Directors. In this role, she leads NAMD's state-to-state learning program, which connects Medicaid agencies to share strategies and address common challenges. Before joining NAMD, Hannah worked in substance use and mental health policy, holding roles at the City of Boston's Office of Recovery Services, the National Center for PTSD at the VA, and the Bloomberg America Health Initiative's Addiction and Overdose team. Hannah, we're super psyched to have you here today, and many thanks to all the fantastic work that you and your colleagues do at NAMD. Please join me in welcoming Hannah today.
Thank you so much, Will, for that really kind introduction. Thank you all so much for being here. A big thank you to the Medicaid Insights Colloquium for having me to talk a little bit about kind of where we are in the Medicaid program now and some of the research priorities that we're hearing about from the Medicaid directors and their teams. So I'll go ahead and share my slides. Okay, I think those are sharing, and I'm sure someone will jump in if they are not. So here's a little preview of what I'm going to cover today. So first, I'll spend some time talking about NAMD. Who are we? What do we do? Then I'll spend just a few minutes kind of talking about the Medicaid program in general. What is the Medicaid program? How does it operate? Then we'll dive into the Medicaid landscape. What are some of the key factors that are going to impact Medicaid agencies over the coming years? And then we'll discuss some of the research needs that we've heard from our members, the Medicaid directors and their teams, as priorities for folks who are working in the Medicaid research space. And then I'll close with some considerations for partnerships with Medicaid agencies, and then we'll have time for Q&A and discussion at the end. So who is NAMD? We are the National Association of Medicaid Directors. We represent the 56 Medicaid directors from the states, DC, and the 5 US territories, and then also work with the senior leaders within the Medicaid agencies. NAMD does our work by elevating thought leadership on policy matters, by amplifying the experience and expertise of state leaders, including through federal policy work, serving as the consensus voice of Medicaid directors in federal policy discussions. And then we also support programs in continuous improvement and innovation by creating spaces for Medicaid agencies to compare notes on strategies and to problem solve around issues that the multiple states are facing. We are led by a 14-person board of directors comprised of the Medicaid directors from the states listed on the slide. So I know that this audience is very familiar with the Medicaid program, so I'm not going to spend a ton of time kind of walking through the basics of the program. As you all know, Medicaid is the primary source of coverage for low-income Americans. Medicaid has a substantial coverage footprint, so covered almost 80 million people as of June 2025. About half of those are kids. Medicaid also has a significant footprint in terms of healthcare spending in the US. So according to KFF, as of 2023, Medicaid accounted for about 19% of healthcare spending. As you all know, Medicaid is a joint state-federal program, so it is jointly funded by the states and the federal government in accordance with what's called the Federal Medical Assistance Percentage, or FMAP. FMAP is essentially the formula that's used to determine how much of the program will be funded by each state or territory, and then how much by the federal government. Medicaid is run by state and territory Medicaid agencies. So state agencies administer the program, they enroll people in coverage, they pay providers. And then Medicaid is regulated by the federal government, so by the Centers for Medicare and Medicaid Services, or CMS. As you all know, Medicaid looks really different state to state in terms of a wide range of factors. So in terms of eligibility, covered benefits, delivery system, rates. Generally, in the Medicaid program, the federal government will set a floor of mandatory eligibility groups and benefits. States and territories can then choose to build on that floor through a variety of optional benefits and optional eligibility groups. There's also a fairly permissive set of federal authorities in the Medicaid program, so states can apply for waivers to test new models or kind of new service arrays. When you think about the Medicaid program, or really kind of any health insurance program, you probably think about a few core functions. So how do people apply for coverage? How do members apply for Medicaid coverage, enroll in coverage, and renew their coverage? How do members get services from providers? So if someone enrolls in Medicaid, how do they find a primary care provider? How do they find a specialist? And then how do those providers get reimbursed for care that they deliver to members? So what is that flow of dollars from states and the federal government to providers to reimburse for care? Behind each of these questions is a really complex array of policy and operational considerations that Medicaid directors and their teams grapple with every day. So when we think about applying for Medicaid coverage, states have to set eligibility policy. In addition to the mandatory eligibility groups, they have to decide which optional eligibility categories they might cover, what income and asset thresholds they'll use for those. States also have to set up systems to actually kind of operationalize those enrollment processes. So hiring teams of caseworkers to process applications and renewals, coordinating with other state agencies like SNAP agencies with which Medicaid eligibility may be integrated, or those agencies may actually kind of run Medicaid eligibility processes. Some states also have their counties run Medicaid eligibility, so a lot of coordination with other government entities. States have to set up these large eligibility IT systems to keep track of who's enrolled, send out renewal forms, and run the ex parte automated renewals. States have to figure out which data sources they're going to use for income and asset verification, and they have to communicate with members around how to apply for coverage and how to renew their coverage. Similarly, when thinking about how members get services from providers, states have to think about benefit design. In addition to the mandatory benefits, which optional and waiver services might they choose to cover. States have to figure out which utilization management criteria, like prior authorization, they'll apply. They have to seek approval from the federal government to be able to claim for those covered services. They have to enroll providers. They have to set up directories of providers so Medicaid members know where they can go for care. And they have to coordinate across the multiple providers that a member might see. And then when we think about reimbursement, states have to set reimbursement rates, either through kind of managed care capitated rate models or direct fee-for-service rates. In managed care states, they have to do oversight of those managed care organizations. States have to set up claims processing systems to kind of manage and pay claims to providers. They have to have program integrity and audit functions to kind of flag any claims patterns that may kind of raise red flags around fraud or abuse in the program. And they have to project the cost of care in the program. So what's the cost of these benefits going to be? And then work with the legislature to fund those benefits. So behind these very kind of core aspects of running a Medicaid program, there's this complex web of policy and operational questions that Medicaid agencies work on every day. And they're often working on those in combination with other state agencies, counties, with vendors, with managed care plans, with providers, et cetera. One of the other complexities of Medicaid is that there are a lot of stakeholders who play a role in Medicaid policymaking. So as you all know, federal policymakers, Congress, federal agencies can play a big role in Medicaid policymaking through statute, through regulation, through guidance. State and federal judges can also mandate changes in the program. The Olmstead ruling in 1999 is kind of a prime example of that, which required Medicaid agencies to rebalance long-term care systems towards home and community-based services. State executive branch officials, so governors, budget officers, Medicaid directors also play a big role in Medicaid policymaking. State legislatures are essential to the functioning of the program. State legislatures pass the state budgets that fund state share of the Medicaid program. And state legislatures can, of course, also pass bills requiring Medicaid policy changes. And then finally, there's a big range of people who are maybe not formal policymakers, but who play a big role in the Medicaid policymaking process. So Medicaid members, providers, advocacy organizations, researchers can all encourage certain policy changes in the program. So to recap that 101, we know that Medicaid has a substantial coverage footprint, accounts for a significant proportion of healthcare spending, about 80 million people, about a fifth of healthcare spending. We know that Medicaid looks really different state to state in terms of eligibility, benefits, delivery models, rates, due to this kind of state-federal model where the federal government sets a floor of mandatory benefits and eligibility groups, and states can choose to build on that floor through a wide variety of options. We know that Medicaid is complex. There are a ton of policy and operational considerations that go into running the program every day. And those are often kind of implemented in partnership with a lot of different stakeholders, vendors, plans, providers, legislatures, other government agencies. And then we know that a lot of different stakeholders impact Medicaid policy. So what's going on in the Medicaid landscape right now? What are some of the factors that Medicaid agencies are going to be focused on over the coming years? So as you all know, it's been an intense few years for the program. That's an understatement. So back in 2020, we had the COVID-19 pandemic emerge. A public health emergency was declared. And Congress actually tied that federal public health emergency to some changes in Medicaid eligibility. We saw the continuous coverage requirement in the program, in which states, in exchange for kind of an increased FMAP rate, kept folks enrolled in their Medicaid program if they became eligible at any point during COVID. Medicaid agencies also took up a lot of new emergency authorities during COVID to ensure access to care during that time. We saw a big expansion of telehealth, for example. And then we saw this big infusion of federal funding into the Medicaid program. Then we had this kind of post-PHE time. So when the public health emergency ended in May 2023, states embarked on the Medicaid unwinding process, so essentially redetermining eligibility for everyone who was enrolled. And we also saw the phase down of some of those federal pandemic funds. Then we had this post-unwinding period where states were navigating the change in administrations and watching the congressional budget reconciliation process. As you all know, Congress did pass a reconciliation bill in July, H.R. 1, One Big Beautiful Bill Act. I'll call that OBA for this presentation. States are now really focused on OBA implementation. So states are really heads down planning for some of the changes. And there's also a lot of work right now to navigate state fiscal constraints. We're seeing a much more constrained fiscal environment for states and for Medicaid agencies. We'll actually dive into that second topic first. So we know that Medicaid agencies right now are grappling with more constrained state fiscal environments. One of the big drivers of this is that we're seeing the combination of slowing state revenue growth and also the end of federal pandemic era funding. We'll walk through that more on the next slide. There are, of course, other factors that are pressuring Medicaid budgets, so new high-cost and blockbuster drugs like the GLP-1s and new sickle cell therapies. We're seeing an aging population, which is putting more pressure on long-term care services. Medicaid's the primary payer for long-term care. We're seeing increases in healthcare labor costs with medical inflation outpacing general inflation. And then we're also seeing some utilization changes in the Medicaid program. So for example, increased utilization of behavioral health services. Medicaid accounts for a fairly sizable proportion of state budgets. So Medicaid costs in FY24 accounted for about 30% of total state expenditures when you combine state and federal, and almost 19% of state general fund expenditures, making it one of the top line items for states. This is, of course, situated within kind of a broader conversation around healthcare cost growth. So we've seen national healthcare costs trend upwards, grow more rapidly than the rest of the economy. Medicaid's actually been more successful than Medicare and commercial in containing that cost growth, but we do still see significant cost growth in Medicaid, so almost 8% in 2023. Here's a slide from the National Association of State Budget Officers looking at changes in state and federal funding for the Medicaid program. So this chart looks at year-over-year changes, kind of by fund source, state versus federal, for the Medicaid program. So you see that from 2019 to about 2022, there was this big increase in federal funds for the program year over year, and a decrease in state funding for the program. And then that actually switched about mid-2022, where now we're seeing big increases in state funding for the program and decreased federal funds. So a lot of pressure on state budgets and a lot of pressure on Medicaid budgets specifically. Almost all states have balanced budget requirements, meaning that their projected expenditures each year cannot be more than their projected revenue. So when states are facing budget shortfalls, when they're in more tight fiscal environments, they oftentimes look to Medicaid to find cost savings because Medicaid is such a big proportion of state budgets. In the simplest terms, Medicaid spending is dependent on the number of members covered by the program, so the number of enrollees, the services those members are receiving, and then the price of those services, so how much the state is paying for the services. So Medicaid agencies really can look at those three factors when they need to reduce spending in the short term. They can look at changes to eligibility, so who's covered by the program. States have to cover the mandatory eligibility groups, but they can look at changes to optional eligibility groups, to eligibility thresholds that are above the federal minimum. They can look at waiver enrollment caps, et cetera. They can look at changes to benefits or the services that members are receiving. So again, have to cover the mandatory benefits, but can look at optional benefit groups, can look at utilization management standards. And then states can look at changes to reimbursement models or how much services cost. So can look at capitation rates in managed care, can look at provider reimbursement rates in fee-for-service. Many states are also exploring value-based care as a strategy for containing healthcare cost growth while also driving quality in the program. So in the short term, states can really look at those three levers: eligibility, benefits, reimbursement, when they need to kind of reduce spending. In the long term, though, we know that Medicaid policymakers are very, very interested in strategies that can help bend that cost curve while preserving access to care for Medicaid members. The other big factor that'll impact Medicaid agencies over the coming years is implementation of H.R. 1 One Big Beautiful Bill Act. We know that OBA will reshape many aspects of Medicaid over the next decade, but it impacts states differently based on their expansion status. Generally, the policies in OBA fall into three buckets: eligibility, financing, and program integrity, and we'll walk through those in a minute. Really, across states, though, Medicaid leaders have a shared goal, which is to implement OBA as efficiently and effectively as possible. States right now are really heads down on planning for implementation of some of the nearer term policies in the legislation. So as I just referenced, OBA will impact states differently based on their expansion status. So based on if they expanded Medicaid to adults who do not have children and do not have qualifying disabilities. Some of the requirements in the legislation affect all or most states, so processes around duplicate enrollment and deceased members or providers, changes to which immigrants are eligible for Medicaid and CHIP, new limits on state-directed payments and provider taxes, new limits on retroactive eligibility for the program. And then some requirements only affect expansion states or states that have waivers that provide minimum essential coverage to the same population. So working community engagement requirements just apply to the expansion population. 6-month redeterminations just apply to the expansion population. Cost sharing just applies to the expansion population. And then the phase down of the hold harmless threshold for provider taxes applies just to expansion states. So diving into some of those policy buckets in more detail, OBA establishes new conditions on Medicaid eligibility. So as folks likely know, expansion states and states with waivers that provide similar coverage will need to implement work and community engagement requirements for expansion enrollees. States will also need to increase the cadence of renewals for expansion enrollees to every 6 months. Those are currently every 12 months. States will also need to implement cost sharing for expansion enrollees. Cost sharing is currently optional in the program. And then across kind of all states, OBA narrows the scope of immigrants who are eligible for Medicaid. There's also a policy around something called the Payment Error Rate Measurement Program or the PERM program. So starting in 2029, the legislation will narrow the ability of HHS to waive fiscal penalties from audit findings in the PERM program that are over 3%. So essentially, HHS will need to kind of levy fiscal penalties when those eligibility and claims errors are over 3% for state Medicaid agencies. There's also a bucket of policies focused on the growth of federal Medicaid spending or Medicaid financing. So we saw congressional policymakers kind of point to this policy aim of controlling federal Medicaid spend growth by making changes to kind of state financing strategies. So OBA prohibits the use of new or increased provider taxes for most provider types. As the name suggests, provider taxes are taxes that states levy on managed care organizations, nursing facilities, hospitals, et cetera, to fund a portion of the state share of their program. And they're near ubiquitous. Every state except Alaska uses provider taxes to fund part of state share. OBA also phases down what's called the hold harmless threshold in expansion states. I'm not going to get into the details around what the hold harmless threshold is, but in effect, this reduces the size of allowable provider taxes in expansion states. OBA also limits state-directed payments to a percentage of Medicare rates instead of average commercial rates. State-directed payments are a mechanism by which states can direct their managed care plans to pay providers according to a certain methodology or rate. So, for example, a state could direct their managed care plan to pay all substance use disorder providers at least a minimum rate in the program. In effect, this policy reduces the size of those allowable state-directed payments. And then the legislation also requires that the CMS Office of the Actuary certify that 1115 waivers are budget neutral to the federal government. The final bucket is really focused on program integrity meaning strategies to address fraud, waste, and abuse in the program. So HHS will be required to create a new system to prevent enrollees from being simultaneously enrolled in two state Medicaid programs. It also requires states to check the death master file to determine if providers or enrollees are deceased. And then again, that kind of PERM-related payment reduction policy. So what are some of the priorities for Medicaid agencies right now around OBA implementation? States are really focused on getting clarity from CMS. We know that CMS will issue both kind of formal regulation and then also guidance on the policies in OBA to give states and territories more detail around how to implement these policies. States are also working on developing their state budget requests. Medicaid agencies are developing budget requests for FY27 right now. In those budget requests, they'll need to project both the cost of implementation for some of the nearer term policies, but then also project how some of the eligibility changes in OBA may impact caseload and case acuity and therefore may impact program cost. Medicaid agencies are also working closely with their state legislatures. State legislatures are going to play a huge role in implementation, one, by providing budget authority to implement the policies, and then two, by amending state statute in certain cases to align state law with some of these federal changes. And then finally, states are really focused on ensuring value from IT systems investments. Medicaid agencies run big IT systems for eligibility and enrollment and for claims processing. Those systems are often quite costly to develop and maintain. And so states are looking to improve some of their IT system procurement and contracting practices, really with the goal of ensuring that those investments in IT systems are generating value for the state and also leading to kind of a good experience for Medicaid members. So what factors are going to impact Medicaid agencies over the coming decade? One, navigating more constrained state fiscal environments. States may need to look at strategies to reduce Medicaid spending in the short term. And then second, OBA implementation. States are really focused right now on implementing OBA, planning for some of the nearer term policies, although we know that states are going to be impacted differently based on their expansion status. So what does this mean for folks who are in the Medicaid research community? What are some of the research priorities that we're hearing from our members? NAMD held a listening session recently where we heard from Medicaid directors and senior leaders around their priorities for research. Medicaid directors and senior agency staff really identified four big buckets of research priorities. mental health and substance use, including cost growth in applied behavioral analysis, which is a service for autism spectrum disorders, OBA implementations, looking at how some of the changes in eligibility in rural health may influence enrollment and outcomes, benefit delivery and trends, including around long-term care, pharmacy, and managed care, and then finally, rates, access, and outcomes. And we'll dive into each of these in detail. So we'll start with the mental health and substance use bucket. Medicaid agencies have pointed to the increases in behavioral health utilization that we've seen kind of coming out of the pandemic. Given the context around state budgets being more constrained, Medicaid directors pointed to a number of areas where it'd be helpful to have more research. So first, what approaches can states take to manage budget pressures while maintaining access to behavioral health services? Kind of the foundational question there. States also had questions along kind of a similar line around what we know about kind of the most foundational evidence-based practices for mental health and substance use disorder. So what services are most critical to improving outcomes? And then are there services where there's actually not a very good evidence base kind of for their efficacy? Medicaid directors also pointed to the overlap of behavioral health interventions. So many individuals are receiving multiple behavioral health interventions. How might those different interventions interact to influence outcomes? And how can we capture efficacy kind of across those overlapping domains of care? So if an individual is in psychotherapy and they're receiving psychiatric medication and also in a work program, how do we understand how those interventions interact to influence outcomes? And then how can we capture kind of outcomes across those different interventions? States also raised a number of questions around the best systems of care for young people with intellectual or developmental disabilities who have significant behavioral health challenges. So Medicaid directors said they're really interested in work around kind of better systems of care, more coordinated systems of care for young people who have the most significant behavioral health needs. And then finally, states pointed to some of the changes that we've seen in recent years to the federal IMD exclusion policy, the Institutions for Mental Diseases Exclusion Policy, and raised questions around how those changes may be impacting institutional versus community-based levels of care within the behavioral health system. States also raised a number of questions around quality measures for mental health and substance use. We know that a lot of process measures like emergency department visits and hospitalization show up when someone's already experiencing fairly acute healthcare outcomes. And so Medicaid directors said they're interested in measures that may indicate mental health and substance use challenges earlier that then can be used to drive early intervention. We also know that a lot of behavioral health measures are tied to claims data. And policymakers are oftentimes interested in outcomes beyond utilization of healthcare. So are interested in if someone has found employment, how their relationships are with their friends and family, their general life satisfaction. So what are the ways to capture outcomes beyond healthcare utilization? Along a similar thread, states asked about patient-defined measures. What measures might reflect what matters to patients in terms of their recovery? And then finally, states highlighted that providers have concerns around over-measurement, especially around behavioral health. And so we may need to think creatively about ways to not just add new measures, but also kind of manage that overall measurement portfolio. So are there measures that are being collected for other purposes that could be leveraged in the Medicaid program? And are there measures that don't work so well that could be sunset or replaced? Next, states raised a number of questions around applied behavioral analysis, which is a service for autism spectrum disorder. Medicaid agencies are reporting really, really rapid increases in utilization and cost, raising questions, of course, around kind of sustainability of those services, but also around program integrity, seeing claims patterns that are kind of raising questions around program integrity in the program. So states asked, what's the evidence on standards of care for young people with autism spectrum disorder? What do we know about which services are effective and at what intensity of services? So what's some of the clinical evidence around some of that best practice for young people with autism spectrum disorder? Next, Medicaid directors asked about the main drivers of cost growth for ABA. And do we see a relationship between ownership structures of some of these ABA practices, such as private equity-backed practices, and some of these trends in cost and utilization? And then finally, what are best practices around program integrity for ABA? And are there any lessons learned from implementation of other services like personal care services or non-emergency medical transportation that were introduced earlier, where we then did see higher risk for kind of fraudulent claims or provider fraud? So what are lessons learned there around ways to kind of control program integrity, watch out for any kind of billing patterns that may be indicative of fraud, waste, and abuse, while still maintaining access to critical services for members? The next bucket of research priorities are around implementation of OBA. So Medicaid agencies pointed to a number of research questions that they're interested in as states implement, especially the eligibility and enrollment policies and the rural health policies in OBA. So first, how will enrollment in Medicaid and CHIP change as a result of OBA implementation? Will we see changes not just in caseload, but also in case acuity? So in kind of the case mix of folks who are on the program. Next, are there lessons learned from the Medicaid unwinding that can inform member outreach under some of the upcoming eligibility changes? So are there strategies around kind of member outreach and communications or around strategies to increase ex parte rates in the program that we learned from the unwinding that then could be applied to some of these eligibility changes in OBA? Next, states will need to implement cost sharing for expansion enrollees. So what do we know about designing cost sharing structures? Are there existing evaluations of cost sharing in Medicaid or in other programs? And what can we learn from that existing body of work? And then finally, states are interested in the Rural Health Transformation Program investments. States just submitted their applications for that program. Those funds are going to be awarded around the end of the year. And as states implement the Rural Health Transformation Program, they're interested in what we can learn around the impacts of investments on access and outcomes in rural areas. So what types of rural health interventions may be most effective in terms of access and outcomes? Next, states pointed to a number of questions around benefits and delivery systems. So we'll start with pharmacy. The context here is that states are balancing the potential positive health impacts of some of the new high cost and blockbuster drugs that we've seen come to market with the very real impacts on state budgets. So GLP-1s like Ozempic and Wegovy are a good example here. States raised a number of questions around GLP-1 specifically. So what impacts are GLP-1s having on health outcomes and costs? Do we see GLP-1s kind of reduce spending in the future on other healthcare services? And if so, on what timeline should states expect to see those savings? That can be really important for state budget development to kind of understand cost trends and when they may expect to see kind of declines in other healthcare spending due to GLP-1s. States also asked about the current research on the durability of health outcomes from GLP-1s. So if an individual is on a GLP-1 for a year or two and then stops, do we see kind of improved health outcomes longer term? States also raised some questions around the new long-acting injectable medications for opioid use disorders. So are there patient populations where these medications may be particularly effective? What do we know about outcomes and costs? And then again, questions around durability. Do we see kind of durable benefits if someone is on these medications and then stops? And then finally, states raised a number of questions around different delivery system models for Medicaid pharmacy benefits. So looking for evaluations of some of the new state approaches to managing the Medicaid pharmacy benefit, like single pharmacy benefit manager models, full managed care carve-outs, and then selective managed care carve-outs for the ultra-high cost drugs. Next, states raised some questions around long-term care services. So over the past couple of decades, states have expanded access to home and community-based services in their Medicaid programs. Home and community-based services, or HCBS, are services, as the name implies, that are delivered in the home and community as opposed to in an institutional long-term care setting like a nursing facility. So states are interested in the impact of HCBS on Medicaid costs. And they asked specifically, do we see an effect of HCBS on reduced nursing home or institutional care placement? So does HCBS kind of act as a way to divert folks from being placed in nursing facilities or institutions? Along a similar thread, what are some of the most effective nursing home diversion strategies? So looking for evaluations around diversion strategies like client education and provider incentives. And does that effectiveness kind of vary between services delivered in someone's home versus more center or group-based services? And then finally, states had some questions around the impact of 1915C waivers. We've seen a big increase in uptake of 1915Cs across states. And states are curious on the impact of 1915Cs on outcomes and cost relative to kind of other level of care settings, and also curious if that effect varies across states. Next, states had questions on managed care. About 2/3 of Medicaid members currently covered through managed care. It's the predominant delivery model. We know that the research on managed care has had kind of variable findings. So states are interested in more research on the impact of managed care on quality of care, health outcomes, cost in the program, and are curious about what factors may be driving some of those variable findings. States are also interested in if there are components of Medicaid managed care, like the care coordination that plans do, that in isolation may contribute to value and improved outcomes. And then the last bucket was focused on the relationship between rates, access, and payment complexity in the program. So against the backdrop of kind of current budget realities, some of the fiscal challenges that states are kind of looking at right now, Medicaid directors are interested on the relationship between kind of rates and provider acceptance, and then some of the other strategies like payment complexity and provider enrollment complexity that may also impact provider acceptance of Medicaid. So Medicaid directors asked, does the relationship between rates and access vary across different provider types? So are some providers more sensitive to rate changes than other providers? And how do we account for state-directed payments or supplemental payments when doing research kind of on rates and access? So if a provider is getting a state-directed payment in managed care or a supplemental payment in fee-for-service in addition to that base rate, how do we kind of fit that into the picture? Next, is there a relationship between rates, delivery models, and quality of care? Kind of what do we know about how to drive quality? States are also interested in the relationship between payment complexity, provider enrollment complexity, and provider acceptance. So if states are in a position where they may not be able to kind of keep giving bigger rate increases, what are some of the practical strategies like reducing payment complexity, reducing provider enrollment complexity that may help increase provider acceptance of Medicaid? And then finally, what do we know about value-based care models? Are there kind of good examples of value-based care models in states that may be most effective for managing cost and improving outcomes in the program? Finally, Medicaid directors pointed to questions around treatment adherence and no-show rates. Some Medicaid directors said, there's kind of this popular idea that Medicaid directors are more likely to no-show or less likely to adhere to treatment plans. Is that true? Do we have empirical research on differences in no-show rates, treatment adherence, kind of across people who are covered by Medicaid versus Medicare versus ESI versus Marketplace? And if we do see differences, what are some of the factors that might be driving those differences? States are also interested in factors or interventions like provider engagement strategies or transportation that may decrease appointment no-show rates, and also in factors or interventions like dose simplification or behavioral interventions that may increase treatment adherence. So again, if we're entering this more constrained state fiscal environment, what are strategies that may help increase the efficiency and the value of care? So to recap, a lot of different research questions and interests from Medicaid directors and their teams, but generally falling into these buckets of mental health and substance use, OBA implementation, benefit delivery and trends, and then rates, access, and outcomes. So our last section is really focused on considerations for working with Medicaid agencies. So first, why should you work with your Medicaid agency? What's the value proposition there? I know that this audience may already be completely sold on this, so I'll just share a couple of thoughts from my perspective. But I think the first thing here is impact. Medicaid agencies make decisions that impact health coverage for almost 80 million people. So by working with your Medicaid agency, your work can directly inform policy decisions that impact a lot of individuals and providers. We know that Medicaid agencies also frequently learn from each other. If there's one evaluation of a new program in a state that looks really successful, other states oftentimes kind of follow that policy. So findings from one state can really have a national impact. Next, I think there are a lot of interesting questions in the program. One of the really intellectually interesting and sometimes overwhelming aspects of working in Medicaid policy is that we see so much variation across states. We essentially have 56 different state and territory examples of how states can kind of implement their programs based off of the same set of federal parameters. And because we have pretty permissive federal authorities in Medicaid, Medicaid agencies are oftentimes innovating, kind of testing new services, new delivery models before other payers do. So a lot of opportunities for kind of interesting research questions by working with your Medicaid agency. And then finally, I think Medicaid agencies can bring insights that may improve your research. Medicaid directors and agency staff have a wealth of experiential knowledge that isn't going to be captured in a data set. It's not going to be captured in kind of a provider enrollment manual on a website. So by working with your Medicaid agency, you can get insights into behind the scenes policy and operational changes that may impact your findings, potential confounders, and also alternative explanations for results. You may see some kind of weird blip in your data one month and be kind of puzzling over what may have caused that. Your Medicaid agency may have some really good ideas around what could have happened there. If you are interested in working with a Medicaid agency, if that last slide sold you, here are some potential considerations. So first, I think it can be really helpful to familiarize yourself with the state or territory context. Medicaid programs operate in really different fiscal, policy, and political environments. So it can be helpful to do some research to understand your governor's priorities in the Medicaid space, your Medicaid agency's priorities, the political context in which they're operating, and then also your state fiscal picture, like how is the budget looking? Always great to meet with your Medicaid agency to understand what issues may be high priority for them for research. And also their timeline for making policy decisions. We know that research and policy making can sometimes operate on different timelines. So it may be helpful to work with your Medicaid agency to understand what topics are going to be the most important to them over the next few years, what types of evidence may be most helpful for making policy decisions, and then some of the timelines there. And then finally, we've heard that it can be helpful to give yourself a lot of time to land data use agreements, governance structures, publication rights, etc. We know that it can take a long time for data use agreements and kind of other aspects of how the work will happen to work their way through the state approval process. And then finally, what are some of the considerations around sharing your research? Probably will not be a surprise that Medicaid directors and other state policymakers often don't have a ton of time to kind of read full published articles. They probably don't have access also to paid journals. So it can be helpful to consider ways to kind of proactively get your work in front of policymakers. We've heard from Medicaid directors that it's really helpful to share your research with Medicaid agencies. So for studies that are conducted on a certain state or territory's program, great if you at least send the final article to that Medicaid agency. States said, though, that kind of the best practice there would be offering to present your paper to the Medicaid director and their teams so that they can discuss your findings, discuss any policy implications, ask you questions. Next, it can be really helpful to develop policy briefs and slide decks to communicate your key findings to policymakers. I had a colleague say about a policy brief, if you have to staple it, it's too long. So think about developing short 1 or 2 page policy briefs and slide decks to really get your work in front of policymakers. Always helpful to put your findings up front and oftentimes helpful to spend less time on methodology than you may in kind of an academic research paper. And then finally, it can be helpful to think about ways to share your information across states. We know that states often model after what they consider to be their peer states, so states who are similar in terms of region, demographics, population size, etc. So exploring ways to make program evaluations accessible is great. You could think about posting kind of high-level summaries of your findings or working with other researchers to post kind of high-level summaries of findings across states. And you could also make sure in your work to really kind of identify some of the program characteristics of the Medicaid agencies that you're studying. So to wrap up, we know that Medicaid is a substantial coverage footprint and accounts for a significant proportion of healthcare spending. Over the coming decade, our sense is that Medicaid agencies are going to be really focused on navigating that more constrained state fiscal environment and then also implementing OBA. Medicaid agencies are interested in research on a lot of topics, including mental health and substance use, OBA implementation, benefits, including long-term care, managed care, and pharmacy, and then also rates, access, quality, and cost. And then it may be helpful to consider working directly with your Medicaid agency on high-impact research questions, or if that's not in the cards, considering kind of proactive ways to communicate your research findings to Medicaid policymakers. So I'll end there. Thank you for your time. You can find NAMD at medicaiddirectors.org, and then my email is also on the screen. And I will stop sharing.
Well, Hannah, thanks so much. That was fantastic and a fire hose in absolutely the best possible way. I think there are in excess of 180 researchers on today. All of us are really, I think, committed to doing work that is of service to states. And I think the last 45 minutes have been a huge service to us in giving us some guidance of state priorities. So we're going to turn now to questions. Again, if you do have a question, please throw it in the Q&A box, and we'll try to get to as many as we can over the next few minutes. Let me start with one that's on mind for me, which is just timeline. My sense is that there are sort of key acute questions where states need the best evidence we have, even if it's imperfect, like tomorrow. There's a set of questions where, maybe there's some time to generate good evidence ahead of OBA implementation, and, evidence that, comes out next fall would really be of service. Then there's the questions that, really are relevant to sort of implementation effects and have a sort of longer timeline. And so I guess thinking about OBA implementation specifically across the many different topics you've mentioned, what are things where you think states need like the best thing we have right now, and even if it's imperfect, that might be helpful? What are the questions where there's more time? And then I guess related to that, one thing that's been on my mind, and I'm sure many folks who do work in this space, is are states going to be getting extensions on work requirements, and how should that think into how we prioritize our work?
Yeah, that's a great set of questions. Maybe I'll kind of start actually with your last question. So as you referenced, there is kind of in the statute around the working community engagement requirements, the option for the HHS secretary to give kind of good faith waiver extensions to give more implementation time. The existing deadline in statute is January 1, 2027, so coming up pretty quickly. CMS did at the MESC conference, the MESS conference, underscored that kind of those waivers will really only be granted in exceptional circumstances, and that states should really be planning for that Jan 1, 2027 implementation time. So I think states are really focused on that implementation deadline and planning for kind of that timeline there. I think your broader question around these different buckets of work is really, really interesting. When we think about working community engagement requirements, states are really heads down, kind of making policy and operational decisions now. A lot of the IT systems changes in Medicaid take a really, really long time to kind of get online. And so even when implementation dates are, a year or so out, states are oftentimes working pretty far in advance to kind of start setting up those systems changes to implement the policies kind of along the timeline. So I think a lot of our members' focus, especially in expansion states right now, is on making some of those kind of early policy and operational decisions around working community engagement. In terms of some of the other policies in OBA, I know states are also really focused on thinking through some of the overlap of the eligibility policies. So what do we know about how some of the 6-month redeterminations, for example, cost sharing requirements may overlay with the working community engagement requirements? So I think that's also a big area of focus for some of those like very, very near-term research questions. In that more kind of medium to long term, as you referenced, I think states are really interested in evaluation as OBA rolls out. So kind of thinking through how caseload case acuity might change, both in terms of kind of the expansion state eligibility changes, but also in some of the broader changes around immigrant eligibility for the program. And then there are some longer term policies within OBA. So some of the PERM policies, for example, come online kind of towards the end of the 2020s. I think there are some of these kind of like big core operational questions in the Medicaid program that states are going to be really focused on for a while, like outside of OBA implementation. So I think a lot of those questions around kind of rates, access outcomes, around value-based care models, around improved strategies for kind of IT systems contracting and value are going to be things that states are going to be focused on probably for the next decade or two. So I think those are probably longer term research questions.
Great, thanks, Hannah. As we've been talking, a couple of folks have asked if you could reshare your email on screen. Can you put your slide back up if you can? Great. Not to inundate you with follow-ups afterward, but I'm sure folks would love to further engage. I guess on this sort of broader question of how best to work with states, we have this question from Catherine Ahrens. Do people who work for Medicaid agencies have time to collaborate with researchers? It seems like they do not. So I guess from your conversations with state Medicaid leaders, what are sort of best practices for how folks can collaborate while also not being a burden and sort of lowering the barriers to entry for collaboration from the state perspective?
Yeah, that's such a great question. And yeah, I think Medicaid directors and their teams do tend to be quite busy, but I think also we're very interested in collaboration. I think if you're interested in kind of getting the lay of the land around the context of your agency, it can be really helpful to kind of look out for public resources, town halls, listening sessions, et cetera, to kind of start to plug in and understand what some of the priorities of the Medicaid agency might be. I think it can also be helpful to kind of have those initial outreaches and conversations, of course, to the Medicaid director, but also thinking through other folks within the agency who might be good contacts. So if you work more in the clinical space, reaching out to the Medicaid medical directors can be really good. Those folks are oftentimes really kind of bringing the clinical expertise to Medicaid agencies, so they can be a good contact. It can always be helpful to go through the association, so NAMD and then the Medicaid Medical Directors Network at Academy Health. And also engaging kind of through existing research consortiums like Academy Health Supplement, Will, like Cornell Health Policy Center, et cetera. And then I think maybe one tip for kind of if you are in a meeting with a Medicaid agency, I think it can be really helpful to kind of have a clear ask up front. And maybe your ask is, oh, I just want to learn more about your priorities. I want to have half an hour to kind of chat about that. Or maybe your ask is, I really want to do an evaluation of this new 1115 that you just got approved. So I think having that clear ask up front can be helpful to kind of make the best use of that time.
That's super, super helpful. I guess again, also thinking about ways to effectively work with and collaborate with states. Research costs money, and so thinking about funding resources that could support state researcher collaborations. There are external funders that we can all think of who do work in this space. Do you think many states have the resources, capacity, ability to leverage state funds to support these types of partnerships at this point in time?
Yeah, that's a great question, especially kind of with the context of the state fiscal situations. We've heard from Medicaid directors and their teams that it can be really hard to kind of justify spend on evaluations or kind of other like quality improvement work if that means that the money's not going to benefits for members, given that that's really kind of the core mission of the program. There are some interesting, though, funding mechanisms in Medicaid for research. So there are some opportunities to get kind of that 50-50 admin match from the federal government on some of the Medicaid evaluations, for example. So I'm unfortunately not an expert in all of the funding streams, but I think there can be good opportunities to kind of work with your state to understand what are some of those potential funding mechanisms. Are there things like 1115 waivers that they need to evaluate anyway that they may be looking for kind of a research partner on? I think those can be good avenues for trying to think creatively around funding.
Great. Um, Moving on to some more topic-specific questions. Nim was asking about whether you think states are looking to make significant changes to Medicaid managed care. For example, maybe even like going back to fee-for-service, like Connecticut. So from your conversations, any sense of sort of what are the changes in that space that states are thinking about where evidence will be helpful?
Yeah, that's such a great question. I think when we think about kind of these like big questions around managed care versus fee-for-service models, those decisions do tend to be made more kind of the governor and state legislature level as opposed to the Medicaid director level. So I think we'll kind of have to watch and see, what states kind of do around managed care. I think there, though, have been a lot of questions around kind of managed care oversight and contracting. What are some of the best practices there to really get value from managed care organizations and to drive those improved outcomes for members? So I think states are really interested kind of in those models. And then also, I think states are interested in kind of understanding what components of managed care, may be kind of the most effective. So does, care coordination, drive improved outcomes? Are there models there that states can kind of bake into their managed care contracts that may kind of help drive value in the program? So I think to the broader question around, will states move away from managed care? I think we'll see kind of how governors and state legislatures think about that question over time. But I think a lot of interest in kind of the model generally. Uh, and I think we've also seen a lot of states kind of look at managed care carve-outs and carve-ins, some of these models that are kind of not purely managed care or fee-for-service for specialty services like specialty behavioral health plans, and then also certain models for some of the ultra high-cost drugs to carve those out of managed care.
Great. I guess another sort of topic-specific question relates to rate changes and rate decreases. So, as you mentioned, this is top of mind as states face meaningful fiscal constraints right now. North Carolina, I know, is notably a state that's already implemented across the board cuts of sort of 3 to 10%, depending on the provider type. Um, can you expand a bit on sort of what the knowledge gaps are here? And I guess one follow-up I'll ask is, some of the best evidence, meaning sort of most causal, most credible evidence we have on the effects of rate changes is very specific to primary care. And so it comes from the primary care fee bump under the ACA. We don't have, I think, as far as I know, broadly speaking, great evidence across other settings. And so I would also say this is an area where there's not great existing evidence across other margins, but where I think many folks on this call would be interested in, again, sort of partnering with states to understand the effect of rate changes in specific settings. And so curious, based on your conversations, if those types of investigations would be of interest to states, even if they can inform things now, might be helpful down the road to understand effects.
Yeah, that's such a great question. Yeah, I think there's a ton of interest from Medicaid agencies and kind of understanding that relationship across different providers. And I think questions around rates are always going to be kind of live in the Medicaid program. And so I think research on these topics will kind of be something that Medicaid agencies are interested in for many, many decades to come. So I think exactly, Will, as you said, research on kind of the relationship between rates and access across different provider types. So hospitals, nursing facilities, dental, et cetera. Do we see that relationship kind of change based off of provider type? We've also had some questions around kind of that relationship between rates and access, and if there's a point where marginal increases or decreases in rates kind of no longer impact access. So, kind of what's that curve of the relationship between rates and access? Are there plateaus? Does that vary across provider types? I think those are some of the questions that the folks have been interested in. And then again, that piece around, given some of the complexity of Medicaid payments, state-directed payments being something that's pretty common in the program, supplemental payments and fee-for-service. How do we capture kind of all of those different payments that may be going to providers and really understand the impacts of some of those kind of non-base rate payment structures on provider acceptance of Medicaid?
Great. Well, that's super helpful. And unfortunately, that puts us just about at time. Hannah, this has been fantastic. As I said, I think everyone on this call wants to be a service to states, and this has been a huge help to us in thinking about how we can best prioritize our work. So thank you so much for taking the time to join us today, and thanks everyone on the call today for investing in this topic as well.
Thank you so much.
Um, so, couple of quick reminders. You'll be receiving a 2-question survey after this session to help us continue to make the program better. Please do take the time to fill that out. And we'll next see you in the new year. That is Wednesday, February 25th, for a mic session with Dan Gorenstein, who's the founder and executive editor of the podcast Trade-Offs. Dan has tons of experience in health policy journalism. And I think in many ways this dovetails well with Hannah's session today. He'll share practical, actionable insights on how to make research more accessible and engaging, and helping us get our work into the hands of folks who can act on it. So don't miss that. You can register on our website, MedicaidInsightsColloquium.com. Thank you all so much for joining us. Thank you again so much, Hannah, and have a great day.